Good morning and welcome viewers. Today we are having the next teleconferencing in the series, and today we will be discussing the course 4 on the clinical and diagnostic and therapeutic services, and I am very happy to have two very distinguished speakers to share with us the different topics. On my left is General Ashim Chakravarti. You are quite familiar with General Ashim Chakravarti. He has been coming here to share his views on the various services, departments, areas in the hospital administration. Let me tell you friends, he is a living legend in the field of hospital and health administration. As you know, he has been the professor and head of the Department of Hospital Administration at Armed Forces Medical College, and then he occupied the position of the Major General in Army Medical Corps, holding very senior position at various places. So thank you very much and welcome General Ashim Chakravarti. And on my right we have another familiar face, Professor J.K. Das, who is Professor and Head of the Department, Medical Care and Hospital Administration, National Institute of Health and Family Welfare. Well friends, we are going to discuss at length number of the clinical, diagnostic and therapeutic areas, and we have divided the areas among ourselves. We will request General Ashim Chakravarti to talk on the operation theatres and intensive care unit. Then Dr. Das will talk about the outpatient department and the nursing services. I will be touching upon the accident and emergency services as well as the ward management. So these are some of the areas that we will be covering in the 3 sessions starting from now. We will break for 15 minutes at 11:45, and then from 12 to 12:45 we will have the second session. Again break for 15 minutes, and then from 1 o'clock to 1:45 we will have the last session. To begin with, let me open the account with a description of the accident and emergency services in the hospital. As you are aware, my friends, there are 2 very important departments in any hospital that you have worked during the medical college's days or you are working now. And these 2 important departments from the hospital management point of view are the accident and emergency services and the outpatient department. These 2 departments we often describe like a mirror or a window into the hospital, and as a hospital manager, if you are able to manage these 2 departments efficiently and in a scientific manner so as to minimize the problems in these departments and increase the level of satisfaction of the patients, then I think half of the battle is won. So not that other departments are not important, we have very important departments, but from the hospital image functioning point of view, I think we have to keep these 2 departments spick and span, and we have to minimize the problems as much as possible. To begin with, some discussion about the accident and emergency services department. As you all know, this is a very crucial service, and this service is known by various names in various states or in various places. Some places we call it casualty, other places we call it trauma service, some places we call it the emergency service, still other places we call it accident and emergency services. But name really does not matter. What is more important is that this service should be organized as a mini hospital within the hospital. I'll repeat. I say that accident and emergency service should be organized as a mini hospital within the hospital. By that, what do you understand? Well friends, let me tell you that we would appreciate that there are questions coming during the teleconferencing from the various places that will help us to know also that you are listening to us, you are interacting with us, and that will also be real purpose of the teleconferencing, that it becomes a interactive teleconferencing. So when I say that the accident emergency services is or should be developed as a mini hospital within the hospital, I mean to say that this service should be independent and should be self-sufficient in its day-to-day functioning, so that the casualty medical officers or the in charge does not have to look up for every little thing to the hospital superintendent or to the other departments for its day-to-day functioning. So that is one of the very important opening statement. I would like to make it very explicit to all of you. And then this service must be organized with one very important aim, and the single most important aim is the resuscitation of the serious patients, those who require, and the management of the serious cases. So resuscitation and maintenance of the three vital functions, that is the cardiovascular, the respiratory and the central nervous system. So these three systems must be, the patient should not only be resuscitated, but the maintenance of these three vital functions assumes greater significance in the accident emergency services department. That means prompt and immediate attention to the patients. That is the hallmark of the accident emergency services, and that's where the casualty takes place within the casualty, isn't it? That's where the promptness of the service becomes the casualty, the efficient service, the life-saving, because it is the golden hour principle. It is the first 1 hour, 2 hours which are crucial to the life and death of the individual. And earlier we rescue and provide relief and resuscitation, first aid, and restore the respiratory passage, the circulatory system is restored, the bleeding points are, the hemorrhagic places are plugged, and the central nervous system is also taken care of. You see, you have done wonderful job. And then of course the patient is taken either to intensive care unit or to the operation theatre, about which we have such a seasoned person to talk to you in detail. So the main role then of the administrator here, the head of the department of the casualty, as the administrator of the casualty, would be to he has to be concerned with the speed of resuscitation within, and sometimes you may be called for a pre-hospital management. That means you may have to send your ambulances to the site of the accident or the disaster or other places, other kind of eventualities. That's where you have to transport the patient vis-a-vis the other parameters that we'll discuss later on. So within the hospital, the speed of resuscitation and the quality and the quantity of resuscitation. The quality and the quantity of resuscitation is your major administrative challenge as well as technical challenge before the persons, before the senior doctors who are working in the casualty or the accident and emergency services department. At the outset, I would also like to say that the sudden and the unexpected nature of an emergency produces a state of panic and a psychological impact on the mind of the relations and attendants. Leave aside the patient, because the patient himself or herself may be too traumatized, unconscious or comatose, semi-comatose. So this sudden and unexpected nature of an emergency must be borne at the back of our mind during the planning considerations and during the day-to-day conduct of the accident and emergency services department. Because the attendants and the relatives of a victim or a patient who has been brought to the casualty are in a state of anxiety, are in a state of shock, and any delay on our part in the casualty or any disregard to the patient or the things will lead to frayed tempers, will lead to quarrels, will lead to conflict, and that's where the problem is are increasing in the casualty management. And as a manager, there is another responsibility on us, that you as a manager as well as the hospital superintendent, the management, should train the staff working in the casualty to keep their cool, to have a composed behavior. And that's where I think, to keep the cool, to keep the composure, a training is required so that you do not lose your temper in the testing times, in times when things become little heated, and that's where we have to try to resolve these kind of situations, which are personnel management, which are the human relations management, which are the public relations management kind of attributes which have to be developed within our personality, or the training has to be given. So casualty, and coming back to the casualty department, how can we define this service? I think this service, we don't have any textbook definition, but we can certainly say that it is a critical area meant for the care of those who are seriously injured or having serious disease problems or are in serious trouble and who require immediate resuscitation. And I'll also like to say that every accident and emergency service department should be so organized that it has all the required equipment and it has all the required manpower, personnel, and all the supplies ready at all the times for round-the-clock care of the acutely ill and injured patients. I would also like to draw your attention that this is the service in a hospital which is normally neglected all over the country, including the capital town of Delhi. Now, it is keeping this in mind, the Government of India in 1978 constituted a very high-powered hospital review committee, famously called as Dr. MMS Sidhu Committee. That was in 1978, and this committee was constituted during the Janta government regime, and this committee was constituted mainly to look into the functioning of the Delhi hospitals, actually the major central government and other hospitals in the capital town of Delhi. And this committee made very vital recommendations on the functioning of the hospitals in Delhi, with special reference to the Accident and Emergency Services Department, and observed, that the Accident and Emergency Services Department of Delhi hospitals, the top hospitals of Delhi, are working at a much lower level of efficiency, and they need to be toned up, and they need to be refurbished, they need to be made more vibrant in the city of Delhi. And these recommendations were made by the time the report was submitted. The government changed, the Congress I government came into power, and the committee's recommendations were of so importance that though normally we see that some government topples, other government comes, the committee also is toppled and the recommendations are not implemented. But this recommendation of Dr. MMS Sidhu was so important that though it was a Janta government time committee, but the Congress government, when came in power in 1981, these recommendations of the Dr. MMS Sidhu committee were accepted and by the Congress government, and were also implemented in the Delhi hospital. When I say implemented, in the Accident Emergency Services Department, it was decided that each shift of the casualty service will have one senior officer of the rank of Chief Medical Officer in all the three shifts. CMO. And that time in 1981, the CMO was very senior position in the Central Health Service, and so 3 senior persons were posted only to see that the Accident Emergency Services Department becomes a functional, vibrant service with the kind of things that we have been talking in the beginning, that it should be, should take care of acutely ill, should take care of resuscitation, should provide quality services and all those things. Now further, if you are working in a, say, district hospital, which is a fairly large 100-200 bedded district hospital or even more, there are certain basic requirements which must be available in every accident and emergency service department, and there are about 7-8 essential requirements for any accident and emergency service. I would like to list them, and I would also request my experts on the dais to further supplement it. But no, I like to list it first, that one of the very basic things that every casualty must have is the adequate supply of splints, actually. The splints are the basic requirement, and sometimes we don't have them in the casualty department. and you know that the immobilization of a severed extremity is so vital for saving, you know, the neurovascular tissues and for the soft tissue injuries, so that we not only save these vital tissues but also immobilize the part with a view to restrict the further damage to the soft tissues and neurovascular tissues. So the adequate supply of splints is the first requirement. The second most important requirement in any casualty is to have a well-equipped ambulance service. That is, you know, much talked about. We have ambulances in our hospitals, especially in the district and the other medical college hospitals, and on an average the ambulance is used for everything and anything except for transporting the casualties and the serious patients. I think that is something really very bad, and that's where the criticism is coming from the community. We must not only have the ambulances available for transporting the serious patients to and fro, but also the ambulances must be equipped with some basic equipment. They must have oxygen cylinder, they must have a suction apparatus, they must have some arrangements for giving the transfusion, they must have the Thomas splints, you know, for immobilization, the cotton bandages, some ambu bag, you know, for the life support, some essential drugs, and the stretcher. And the stretcher bearer must be trained. The driver and the stretcher bearer must be trained in cardiopulmonary resuscitation. I mean, these are some of the very basic things that you know, in any ambulance which is going out of the hospital and, you know, bringing the casualty must have the support. And then of course we have very hi-fi ambulances, which are coronary care ambulances with all the gadgets and equipments for the pace making, for the defibrillation, for the you know, echo, and for doing all kinds of you know, providing all emergency relief to the patient who has had a acute myocardial infarction, etc. So this is the second most important requirement. The third important thing is that every casualty service should have the facilities to manage certain type of cases on priority, like poisoning, drowning, snake bite. You know, these are some of the things which are, you know, immediately life-threatening things. And then of course the management of all acute medical and surgical emergencies, including myocardial infarction that I mentioned. Myocardial infarction is the #1 killer among the adults in this country and many other countries. So I think the casualty must be equipped to immediately try to rescue and to provide you know, immediate care to the patient, and then transport the patient to the coronary care unit. The first and foremost thing in the casualty is that the ECG machine should be functional, that we should have a portable defibrillator in the casualty department, and the people who are working in the casualty must be trained to use the defibrillator. Sometimes there may be cardiac arrest, and by the time you transport the patient to the ICCU, it may be too late. So maybe that we have the senior resident from cardiology rushed immediately to you know, look after the patient, but in the meantime the casualty staff should also be able to do the defibrillation of the patient to save the life. The fourth important requirement is that we must have the emergency operation theatre, you see, for minor surgeries, and even certain life-threatening surgeries may be carried out within the emergency operation theatre inside the premises or within the precincts of the accident emergency services department. The fifth important requirement is that every staff in the casualty must be trained in cardiopulmonary resuscitation. This is simple, but I think we must try to carry out exercises. We must try to see that yes, the people are trained in the cardiopulmonary resuscitation through the dummies, etc. And then next important requirement is that we must have easy access to the radiological and emergency laboratory services. Very important. So the imaging and laboratory services availability, and the essential therapeutic, diagnostic therapeutic services, that the drugs, essential drugs, life-saving drugs, and we must have a proper inventory of those drugs in the casualty department, including injections, tablets, dressing material, etc. Anesthetic drugs, local anesthetics. The next important requirement for any casualty, I'm just talking of the basic minimum requirement or the essential features or requirements in the casualty, would be that we must have a recovery ward. A recovery ward attached to the casualty department besides the observation beds. So you can combine the functions of the two, observation beds and the recovery ward. Another very important requirement is that the efficient, that casualty should have efficient and courteous staff in the casualty department. That we made an opening announcement, so that the staff working in the casualty should be given a special training in these kind of behavioral techniques. So efficient and courteous staff is a very, very important feature in the accident and emergency services department. Then we should have a disaster manual. A disaster management exercise should be carried out. Mock drills should be carried out, because these days, as you see, we are having man-made or natural disasters, and the frequency is increasing. Anytime the hospital may be suddenly faced with a rush of 50, 100, 200 patients being brought in a very serious condition, and then we may have to do the triage in the casualty and immediately try to save the patients who can be saved by providing resuscitation and transporting them to ICU or operation theatre. So you see, these are some of the basic requirements that I thought I must share with you, that which must be considered in the planning and organization of the Accident and Emergency Services Department. Before I go on further, may I invite Sir General Ashim Chakravarti to further supplement whatever I have said so far.
Thank you, Dr. Agarwal. Dr. Agarwal has given you a very lucid overview of the basics of the Accident and Emergency Department, and he has made the point, and I wish to stress on that point, that this is a service which functions 24/7 into 365, and therefore they have to be organized in such a manner that the emergencies, feared or real, whatever may be the case, are afforded the optimum treatment as and when they come inside the A&E department. The other point I would like to stress upon is now that the disaster management, which Dr. Agarwal touched upon, that the entire disaster management plan is built around the capabilities of the Accident and Emergency Department. It is the disaster, we call it a disaster when the normal department is unable to cope with the workload, and therefore one has to plan that what should be the receiving area, the holding area, the triage area, and what would be the flow pattern of this sudden spurt or the sudden increase in the number of people seeking attention at the Accident and Emergency Department. Otherwise, there is a chance that the department will be swamped and will be put to such a great stress and overload, that the services may be badly compromised. So therefore, these plans have to be made ahead. I don't want this. I don't want this. So those plans will have to be made ahead, and one has to keep in mind that the areas required for this increased workload to manage the disaster situations may be earmarked much ahead, but be used for other purposes when there is routine daily functioning. Another one more little point I would like to stress is that the arrivals at the Accident and Emergency Department, it is now well documented that 50 to 60% of the cases which report to the Accident and Emergency Department are to be categorized as trauma patients. Thus, it necessitates that trauma must be given special consideration while planning a accident and emergency department, because if 60% of the patients are going to be falling in the category of trauma, we require to have a little additional thought on how to provide trauma care, how to provide specific space for trauma management, resuscitation, and their aftercare, and their getting them inside the definitive line of treatment. That's all. He has made a point about the ambulances. It is high time that we have proper ambulances. Ambulances, we must realize, they are specialized vehicles and not load carriers. And if they are specialized vehicles, they must be made specialized. They must be treated as specialized vehicles, where the patient must be able to be given ABC, airway, breathing, circulation, must be attended to. And now you have ambulances which can communicate with the main hospital while picking up patients, and they are also given advice on the treatment protocols from the main hospital. They are monitored from there. The patient parameters, vital parameters are monitored from the main hospital, and those are easily attainable now, and some of the hospitals have now implemented such type of ambulance services. Yes, Dr. Agarwal.
Thank you very much, General Ashim Chakravarti. Before I invite some comments from Professor Das here, I would like to just say a few more points about the supervision and about the staffing and general guidelines with regard to the organization and the staffing in the casualty department. Now, who should be responsible for the day-to-day supervision or the head of the department of this service? I think it can be any senior doctor who is especially skilled in accidents and industrial injury, and is also thoroughly familiar with the medical legal procedures and also certain other laws like Workmen Compensation Act, insurance laws, etc. But the person should be dedicated, committed to this service. As we have been discussing, this is a very, very important department, and it means, in a few minutes, or it is just question of few minutes or half an hour or first hour, that will make a difference for the patient's life or death. So the supervision has to be very meticulous, and a senior person with special skills must be. It could be a surgeon, it could be a physician, it could be an anesthetist, or anybody, any senior doctor could be in charge of this service. Then about the organization norms, guidelines for the norms of staffing and imaging and laboratory, we would like to say that as a rule of thumb, normally 40% of the patients coming to the casualty require radiological investigations, and nearly 20% of the patients coming to the casualty require laboratory investigations. I am not talking of the disaster situations. I am talking of the normal casualty functioning. It may vary in the disaster situations. And then how many doctors and nurses in a general hospital, casualty department? It is estimated that if the workload is, say, 100 patients every day in 24 hours in the casualty, we need the services of at least 7 nurses and 6 doctors distributed over the 3 shifts. So that is another parameter which has to be kept in mind as a rule of thumb, that we, for every 100 patients, and then we can extrapolate and calculate for the less number or the more number, we need for every 100 patients 7 nurses and 6 doctors to be divided into the 3 shifts, with some extra leave duty reserved for taking care of their leaves and offs. And if the patient volume, there is another guideline, that if the patient volume exceeds, in this department, exceeds 1,000 patients per month, then we need to have one separate X-ray department, X-ray unit rather, a separate X-ray machine working 24 hours attached with the casualty department. So these are some of the guidelines, which we thought from the staffing and from the organization point of view. Do you have anything to add further and supplement, Dr. Das, here something? Your comments?
Thank you, Professor Agarwal, and I think all the important aspects for this management of emergency services in a hospital has been taken care of. But Well, just to add on few to this, like Professor Agarwal mentioned that you need to have some beds, observation beds in the emergency department. Well, the normal rule says that 20%, 10% of the patients who are visiting the hospital, may develop some kind of emergency situation for which we require to have this kind of facility in the form of wards. And when 10% of the total hospital bed strength should be earmarked for this emergency wards. But there are some word of caution, because in most of our hospitals we have seen these are the services or these are the wards are always overcrowded, overflooded. Even you will find the patients are lying on the floor or in the stretchers. Now Professor Agarwal mentioned two things, that there's observation beds and this recovery beds or the emergency wards. Now there should be strict policy decision first and foremost for the admission, and next is that discharge or transfer of the patient to the various nursing care units of the hospital. For the observation beds, the hospital must have that policy that for what duration the patient should be kept under observation. If you are not doing that, what will happen? All the observation beds, all the trolleys will be occupied by the patients, lying from days together, occupying these facilities for days together, and all the facilities and services which are available to the emergency department for a limited capacity of your beds will be shared upon by these beds also. And in most of our hospitals we have seen that almost 3 times of our capacity we are dealing with for this kind of patients who are lying in the stretchers or the floors. So whenever you are keeping any patient for observation, see to it they should not be kept under observation for not more than 2 to 4 hours. Maximum you can go for 6 hours, but not more than that. After that, either you decide to admit the patient or transfer or refer the patient. But if you are doing that, that means with your limited human resource facility, with your limited equipments and the drugs, you are dealing with the more number of patients. Similarly, for your observation beds also, in most of the hospitals it is seen that the patients are being kept there, and sometimes some critical patients are also being kept there. The reason being this, the people think that doctors are round the clock available there, hence that emergency this critical care patients will also be taken care of. It is a very wrong notion, because critical care patients are to be dealt out absolutely in a separate manner, and General Chakravarti is going to take up that session in detail, and you will also realize how important it is. So emergency ward and the critical care wards are not to be mixed up, and the patients who are being kept into the emergency ward as per the policy should not be kept for more than 24 hours. Once the patient is required to be kept in the hospital or for the sake of the treatment, the patient need to be continued to stay in the hospital. It is better to shift the patient either to the general ward or to the step down ward or the high dependency ward or to the critical care areas, but not in the emergency ward, and never more than 24 hours. If you don't do this, if your turnover in these wards are not high, you will not be able to accommodate the other incoming serious patients in the hospitals. And these are the problems basically been found in our district level hospital and the medical college hospitals too. This is one thing. Second problem is this, as Professor Agarwal very rightly said, we must have some very dedicated, highly motivated staff working in the hospital, and they need to be very courteous. Unfortunately, in our hospitals we have seen for every department we have got some definite or dedicated staff, but for the emergency department they are always been posted or withdrawn type of staff. And there is a common feeling among the staff also that if you are getting a posting in the emergency department, it is almost equal to a punishment posting, and staff are also highly demotivated. That kind of thing need to be removed, and we need to see to it that emergency department is also a very, very crucial and critical department, and a lot of, not only that medical service you are providing, lot of social or community service also you are providing through this department. So you need to put those people in that area where that people can work with lot of motivation and dedication, and of course they should be highly trained also, particularly to look into the aspects of resuscitative measures. I think That's
This is
what
very
I
good.
can.
Thank you. I think we had a lot of enrichment both by General Chakravarti and by Professor Das, and the points that have been made. Dr. Das, you are very right that with the patients when they are kept in the recovery ward, they are just kept indefinitely. That's wrong. Actually, let me give you Safdarjung Hospital experience. That there in Safdarjung Hospital, where I was working for some years in the administration capacity, in the administration, then you see in the casualty department of Safdarjung Hospital, that time we were having 2 wards attached to the casualty. That is, ward A was the medical ward and ward B was the emergency surgical ward, emergency medical, emergency surgical ward. And then the casualty itself had about 6 to 8 observation beds, and then besides the examination cubicles. I think in the planning and organization we have to see these things, that within the under one roof of the casualty department, the planning should be so done that we have the doctor's station, we have a nurse's station, then we have on one side the examination cubicles, then we have some toilet facilities, then we have the observation or patient holding area, where the patients come for a couple of hours and then they are given the first aid like status asthmaticus or hyperpyrexia or acute MI or injuries. Immediately after giving the first aid, they are either referred, if they are medical cases, referred to the emergency medical ward, and if they are surgical cases, they are referred to the emergency surgical ward. But the point that Dr. Das has made is very important, that we don't keep them in these emergency wards for more than 24 hours. So what used to be done, that every day whosoever had the medical OPD or the surgical OPD, that day will be the responsibility of that unit, medical or surgical unit, to manage the emergency ward or the surgical ward as the case may be, and their resident doctors will be manning these emergency wards on that day. And then by the next morning they will either discharge or transfer the cases to their respective ward. So that is the kind of guideline that we can follow in our hospitals as well, that on the next day or after 24 hours or less than 24 hours, either we discharge the patient from the casualty wards itself, or they are transferred to the respective concerned wards after the resident doctors or the senior doctors have examined the patient. Then another thing before we conclude the discussion on the emergency services is that I would like to take a few minutes that you may be wondering that the same principles should be applied to a tertiary care emergency department and same should be applied to a subdivisional hospitals. No, actually the accident emergency services are classified, and there are 4 basic classifications of the accident and emergency services. The highest level we can call it, I mean this is one classification which has been propounded and which has been accepted in the hospital administration, that the tertiary care hospitals, large hospitals, will have the major emergency facility. Now when do we call it major? The major emergency facility would be one which has 24-hour availability of all the specialists immediately within the hospital. Either they are within the casualty or they are just around in any department of the hospital, so that they are immediately available. So 24-hour availability of the various specialists in the hospital on the spot, almost within minutes they are available. Yes, please, Jaipur, come on.
Very good morning, sir. This is Dr. Prasad calling from RC Jaipur.
Oh yes, Dr.
We are
Prasad.
very happy to inform you that we are a few students at regional center. Apart from here, we are also having students at Ajmer and Jodhpur. Here we have a doctor called Dr. Ashok Kumawat. He wants to put a question to you. I'm handing over the phone to Dr. Kumawat.
Yes, Dr. Kumar.
I want to ask you one question.
Yes, please.
Services. How many types of special services must be there 24 hours within the casualties?
Okay. Thank you.
Because in our SMS hospital, all the specialists are on call.
Yes.
Most of the specialists.
Yes.
So I want to ask you, in such type of hospital,
Yes.
how many types of the specialist services must be there every time?
Thank you. Thank you. I think it's a very good question, and that's what we were talking about at the moment, that SMS Medical College Hospital, which is a tertiary care hospital, big hospital, must have 24-hour availability of a physician, a anesthetist, to provide, immediately the kind of resuscitative measures, where the ventilation has to be maintained and other functions have to be maintained. And then we must have the services of a surgeon, the orthopedic surgeon. So these are, basic, and
Pediatrician.
and obs-gynae and pediatrics. So these are the specialties which must be available. And then, of course, when it comes to super specialties, we need to immediately call the senior residents of the super specialists from the respective super specialist departments. So a surgeon, a physician, a orthopedic surgeon, a pediatrician, a gynecologist, they must be available within minutes in the main casualty department of a facility like SMS Medical College. Would you like to add something else here?
No, you're right, very right, Professor Agarwal, that SMS is a tertiary care teaching hospital, and therefore it is incumbent that all specialties are available round the clock, on call, and in-house. Available in the A&E department must be the physician, surgeon, the anesthetist, the pediatrician. They have to be there immediately available for all patients who arrive at the department.
Thank you. Then, we have just 2 minutes left for winding up this session. So major emergency facility, and then it has to be supported by all the diagnostic therapeutic equipments and linkages with ICU and OT. And then the second lower would be the basic emergency facility like a district hospital, where we have 24-hour general duty medical officer present physically in the casualty and the specialists on call. So this would be the second, we call it basic emergency facility. And then third is the standby emergency facility, which will go down to the community health center in the peripheral areas, where a nursing officer is on, a staff nurse is on 24-hour duty by shift, and a medical officer is on call. And then, fourth one, of course, is for the sub-center and referral emergency facility. Very right. So I think with this, I'm grateful to Jaipur for asking a question, and I will request the other centers to ask more questions. We will again meet at 12 o'clock, and then we'll request General Ashim Chakravarti to talk on the intensive care unit. Thank you very much.